All right, we're going to get started today. Local anesthetics is something that you're going to be using a lot of. What always amazes me is how little practical training people get for local anesthetics. Everybody sort of assumes that you know how to use this stuff, which is not really the truth. So what I'm going to try to do is give you the actual background information to know how these medications work, but also will give you a little bit of practicality so when you get into clinical you don't get into trouble. So I'll show you some of the pitfalls of trying to avoid. What we're going to go through is we're going to go through the commercial preparations, why they're prepared the way they are, how it actually alters your therapeutic management of the patient. Then we'll go into structure-activity relationships, mechanisms of action. Then we'll talk about minimum concentration, which is equivalent to MAC when you're talking about local anesthetics. Pharmacokinetic principles, side effects, and then we'll talk about individual local anesthetics, and we'll also talk about in detail some of the principles of pharmacokinetics that are always asked on certification exams and also asked on my exam. So, the first thing is what would be a perfect local anesthetic? And we're still searching for it. We've gotten pretty good at what we have, but it's not perfect. The first thing we want to have is something that's non-irritating to tissues, that would not cause any permanent damage to a nerve structure, which means that it would always have reversible activity. It would have minimal or no systemic toxicity, and I'll show you as we go along that there's a lot of systemic toxicity with these agents. And that's why you always have to keep that in consideration when people tell you, well, you know, regional anesthesia is safer than general anesthetics. Well, they don't take into consideration the systemic toxicity of these medications. So that's not always necessarily true. I've seen disasters from regional anesthetics just as bad as a general anesthetic. So things can happen no matter which way you do this. You want to be effective as injected or applied topically to mucosal membranes. You want to have very short onset of action, which means you want to have it act very quickly. And then you want it to work long enough so you don't have to re-inject. And you don't want to develop what's called tachyphylaxis, which means on repeating dosages, there's no downregulation of receptors, which results in inactivity of the medication, which is something that you would definitely not want. Now, if you look at the history of local anesthetics, it goes back to South America. The first actual local anesthetic to be discovered was discovered very long ago, and actually was by the Incas in Peru. They actually used this leaf, which was a coca leaf, which is it's called the erythroxylon coca shrub, as a stimulant. They also used it as a local anesthetic, and they used it in certain situations where they did even trepanations using it. What the coca leaves basically will do is when you chew it, it will numb up your mouth. And that's how they figured out that there was something going on. And one of the travelers in the 1800s into Peru area found that the native people were chewing this stuff, and he did that, and he noticed that his mouth became numb. And was mostly related to his bad teeth. The Englishmen had pretty bad teeth because they had scurvy from traveling across the ocean. And they noticed that as soon as after he got this exposure to this coca leaf, that his mouth was numb, and he didn't have any more dental pain. They thought it was kind of cool, so he brought it back, and brought it back as a leaf. That's when we still have the coca leaves. The coca, its leaves itself, is something that the people still use, and it's not illegal. It's the concentrated material that becomes much more dangerous. People are not really, debilitated by it. It's actually pretty good for altitude, and it kills hunger, which is another thing that it does. But it was first isolated completely in 1860, and in 1884 it was introduced as a local anesthetic by Kohler for eye surgery. So the first use of cocaine was for eye surgery, ophthalmic procedures, as well as dentistry, which is where the initial thought of it was from. The good thing about cocaine is that it's a very intense vasoconstrictor, so it's also very useful for dental and ENT procedures because it decreases the blood flow to the mucosa. You get less bleeding when you're doing procedures, so in that sense it's a pretty helpful local anesthetic. The downside to it is that so many people became, and still today, develop the toxicity of prolonged use, and they began abusing the drug. People that are pretty famous that you might not know have been involved with cocaine. Freud was one of them. Freud had a cocaine addiction. And many of the physicians that initially started using this stuff, they self-injected this stuff first to see how it would work. And unfortunately, they got hooked on this material, and many of them died from complications of that. In 1892, they kept searching for a synthetic substitute for cocaine, and the Germans were able to produce in 1905 the first synthetic local anesthetic, which is procaine. Procaine and cocaine have very similar appearances, and we'll show you how all local anesthetics have. And then in 1943, lidocaine became developed and actually quickly became the gold standard of local anesthetic agents, and still is today one of the primary local anesthetics that we use. The commercial preparations of it is unfortunately, local anesthetics are very poorly soluble agents. They don't stay well ionized. And in a normal pH or an alkaline pH, they fall out of solution almost immediately. So, because local anesthetics are bases, the only way to make them charged is to put it in a strongly acidic solution. And if you look at this lidocaine, you'll see beside it HCl, which is hydrochloric acid. The reason they're putting the hydrochloric acid is to ionize the local anesthetic and to stay suspended in solution. Okay, so when you look at the actual commercial preparation with the hydrochloric acid, they drive the pH down to around 6, which is not too bad. Okay, it will still cause a lot of discomfort when you inject, but it's not too bad. What really happens really badly is when they add epinephrine. When epinephrine is added, epinephrine breaks down and is very unstable in non-acidic environments. So they actually will add another compound called sodium bisulfite, which will decrease the pH down to 4. So when you're adding lidocaine with epinephrine, that is actually much more painful than if you use just straight lidocaine. There's differences in pH. The downside to the acidic solutions is they cause a lot of pain, and they slows down the onset of local anesthetics because once they enter into your skin, they must convert back to a normalized pH, which takes a few seconds, and then it becomes unionized, and that's what penetrates into your tissue. You really have to have the unionized fraction so it become lipid soluble and penetrate the actual tissue and the cells to cause the effect. Now, there's other commercial preparations. There's things called liposomal local anesthetics, which we haven't seen too much in the United States just yet, but they might be coming down the pike. What that basically is, it's almost like Diprovan. It's got like a lipid carrier. It's a lot less painful, but the downside to it is it takes a little bit longer for it to set up. But what we see the possible uses for it will be for long-term pain relief. When you inject these medications, the duration of action could be as long as 96 hours. That would be a great thing if you could put in an interscalene block in somebody and shut down their pain for 3 days. I mean, that would be like magical. And patients would tend to do better. So if you had a holy grail, that's what you'd want to do. And we also find that these new drugs apparently have less toxicity. So not only do they have long duration of action, but now they have no toxicity. The downside to it, of course, if you get an interscalene block and you knock out the phrenic nerve, that person's lungs will be down for 3 days, which may be a little bit of a problem. Okay? Now, the other thing that I found innovative is that we've been using topical creams for a long time in pediatrics. The limitation on it is it takes 30 to 60 minutes for the actual medication to penetrate through the skin. The typical example of that's Emla. They have some new things that are coming down the pike, which is, when I was a student, they were experimenting with what's called iontophoresis, which we would put the Emla cream on, and then we would put charge over it, and it would push the molecule in by ion charge. That works pretty well, but kids sort of freak out when you start putting anything on their hand. They don't like it. So they came about with this new thing, which is a powdered local anesthetic, which is lidocaine. And then they have helium as a gas delivery system, which pushes the molecules into the kids. This has been found pretty effective so far. They're still having some problems with skin in the sense it forms erythema, so there's a little concern if this is going to cause some kind of allergic reaction. But so far, it's still in experimental stages, but maybe it's something you'll have in the future, and you will be able to put an IV in a kid beforehand without any pain, which is pretty interesting. Anything to decrease discomfort to kids is a good idea. You also look at the commercial preparation. What can you do is if you have this preparation that is very acidic, is that you can alkalize it right before you use it. And most of us will try to do this when we have somebody who has a lot of anxiety and you have very big concerns about causing any kind of discomfort. By adding a little bit of bicarb, you can really change how the medication works. One of the things that will happen is when you add that alkalization is you'll shorten the onset time, so it will set up a lot faster. It decreases the pain on injection. The downside to it is that it may actually precipitate the local anesthetic, and you'll see crystallization. If you did that, you just messed up, and it's time to throw it away. Okay, you can't do it that way. You've got to redo it. The way it's recommended to add the bicarb is you pull the medication first into your syringe, and then you add a little bicarb to it. Never put the bicarb in first, because when you pull in the solution, then it's in high concentrations when it impacts it, and then it causes precipitation to take place. So just knowing that little simple trick can make it from being a disaster to actually make it work. It actually, if you look at the peripheral nerve blocks and for epidural blockade, it can shorten the onset time by as much as 3 to 5 minutes, which really makes a difference. If you're taking care of somebody in OB and you want bupivacaine to work faster, just add a little bit of bicarb. It makes a huge difference. It can set up much more rapidly that way on the patient. Now, if you look at the local anesthetic, the way it's made up of 3 different components. It's got a lipid-soluble component, an intermediate chain, and a water-soluble component. And depending on how the local anesthetic is set up molecularly, you can make the thing either more lipid-soluble or more water-soluble. Now, let's go on to talk about a little bit how the medications work. This is going back to the basics, so I'm just going to go very briefly over this. It's the anatomy of the peripheral nerves. Remember that we talked about axons before. The axons are the component of the neuron that carries the nerve signal down to the nerve ending. This is where the local anesthetic works. The local anesthetic works by inhibiting fast sodium channels on the axon. Now, if you have unmyelinated fibers, it takes very little local anesthetic to knock out that axon. The reason being is that the distance between the sodium channels to knock out enough of them to cause lack of wave dissipation or electrical energy dissipation to the axon is fairly easy to knock out. But if you have myelinated fibers where you have distant nodes around VA, that means that you have to increase your volume to actually get the same effect. So myelinated fibers are more difficult to block, and it takes up to 3 nodes around VA in a myelinated fiber to knock it out. Now, the axial lemma is the cell membrane that the local anesthetic must penetrate to work. The local anesthetic will not work on the surface of the axon. It has to go into the cell to have its effect. So that means if it's ionized, it won't work. It has to go to its unionized state so it becomes lipid soluble, so it can penetrate through the cell membrane and then work in the axoplasm, which is the cytoplasm of the axon, and goes up and penetrates in the back side or the intracellular component of the sodium channel. So it does not work on the outside portion of it. Remember, we talked about Schwann cells before. These are the actual wrappings. Every cell in your body pretty much has Schwann cells around it. It just depends on how much myelination the Schwann cell supports. The more the Schwann cell produces myelination, the more difficult it is to block that axon. Now, the nodes around VA are small segments of nerves that do not contain any myelin. I talked about this before, so I'm going over it briefly. The sodium channels are located right in the nodes around VA, and that's where the local anesthetic is going to work. Okay? It's not going to work anywhere on the myelin sheets because there's no sodium channels, and doesn't even penetrate that well through that thick lipid membrane, which is the myelin. So the local anesthetic will preferentially go through the areas of the nodes around VA, which is kind of good because that's where the sodium channels are able to be knocked out. Okay? What this picture is showing you is that there's 3 nodes around VA. It takes that many to effectively shut down that axon completely for it to be functional. If you look at the anatomy of way nerves are, when we're looking at peripheral nerve blocks like the interscalene blocks or anywhere else where we're talking about, it's not just a single nerve fiber. It's a component of many different kinds of actual axons that are going through this nerve. Some of the axon material is going afferent, which is going towards the spinal cord, and some of it's going efferent, which is motor, going outwards. So the nerve contains both these kind of things which we call fasciculi. Fasciculi are basically bundles of axons that are coming together to travel together towards the nerve, to the muscle, or to the area where they're supposed to innervate. The actual nerve itself has layers to it, which makes it more difficult for the local anesthetic to penetrate. Now, how near you get to a nerve depends on your training in the sense of how secure you feel about it. My personal feeling is I try to get close to the nerve, but I never want to touch it. And I was always trained that way. Don't touch the nerve, okay? Other people were taught, just hit the nerve until you get paresthesias. That just doesn't make sense to me. And a lot of my professors kept telling me, if you hit a nerve and you're getting shooting pain down it, that means you put the needle into the nerve and you're hurting the axons. Okay, so that makes more sense to me. And so when I use ultrasound, you'll see me get really close to the nerve, but you'll see me never try to touch it. And we'll just get to close proximity and then inject the local anesthetic. Now, what happens if you inject the local anesthetic directly inside the nerves like this, inside the fascicular components? You will cause disruption of axons, and you will kill that nerve. So you got to be, and it takes months to get recovery from it. So where you're injecting is all along the outside layer out here, okay, which is called the epineurium. The perineurium is the next layer below that. That's investing itself around individual axons, and the endoneurium is the closest one, okay, which is pretty thin. Each of these layers acts like a barrier. Okay, one of the things that's really cool in the last few years is that we've moved on to using a lot of ultrasonography. And when we inject the local anesthetics, before you inject it, the nerves are kind of hard to see. But when you inject the local anesthetic, you'll see that the nerves will become enhanced. The fluid that you just injected now surround the nerve, because the nerve is covered in this epineurium. It really sort of isolates it. And you can see that the local anesthetic literally will bathe the actual nerve. And depending on how thick the nerve is, and you can actually see the differences now. You know, we always thought there was differences, but it seems like women have much smaller nerves, and as a consequence, they're easier to block. Men tend to have thicker nerve components, and they're a little bit more difficult to block. It takes longer for the local anesthetic to kick in. It will still work, but it just takes longer for the onset time to set up. And that's simply from these different layers that you've got to get through. The action potential is what you're trying to disrupt. You're trying to eliminate the actual axon from depolarizing. So what you're eliminating is the fast sodium channels and these axons. So local anesthetics works specifically at the fast sodium channels, and they don't really affect the sodium-potassium ATP pump. They don't really affect the potassium pump. They only selectively knock out the rapid sodium channels. So what you're eliminating basically is phase 0, okay, in this patient. The action, remember, the action potential is a prime mechanism to make you stay at the resting memory potential as your sodium-potassium ATP pump. And once the cell becomes depolarized by the fast sodium channels. What repolarizes them is the potassium. The membrane is also relatively permeable to outward diffusion of potassium, which makes it more negatively charged. This is all the resting membrane potential. And if you look at the intracellular to extracellular ratios, it's basically 30 to 1 for potassium, which makes it pretty important. Sodium, on the other, and other ions are impermeable to the axial lemma only when you have the sodium channels open. So that's very specific to certain channels, and that's how the local anesthetics that inhibit this action can be very effective. Let's say we did that already. Okay. There's two opposing forces are constantly in play when you're talking about the actual axon. You have the concentration gradient pushes potassium out of the cell, while negatively charged keeps potassium in the cell. And then the net result is a net modest movement of potassium out of the cell. This process is expressed by the Nernst equation. Remember, if you're actually looking at inside the charge of the axon, it would be 0. But when the comparison is made between the outside and inside world, the charge inside the axon is actually negative, so usually minus 70 to minus 60. And that gives you a resting amount of energy that if you open up the sodium channels, you can cause rapid change in electrical charge, which drives it up to plus 0 and above higher than that. And then repolarization occurs by the potassium channels. So here's how the local anesthetics will tend to work. The sodium channels by themselves have three functional states. They have closed, open, or inactive. And we think that these sodium channels are not like the acetylcholine sodium channels where they have two double gates. These appear to have one single gate that opens and closes. When you have the inactivated state, the actual sodium channel will not allow sodium to pass through, but it still allows sodium inside the channel itself, but it does not allow it to come out. For actually become reactivated again, it must close completely, which is the second component of it, and then the thing can refire and be reused again. So it's a whole stepwise process. Now, why is this important? Well, because the local anesthetics inhibit in two places. We know that local anesthetics inhibit the actual closing point down here, and will actually enhance that activity, will maintain the sodium channel in a closed state. Or if the local anesthetic goes through the channel and binds inside and inactivates it that way. This is more dangerous because it's more difficult for the cell to get rid of it. So some of the toxicity to cellular damage is thought to be that you permanently inactivate sodium channels by the local anesthetic penetrating into the actual middle of the sodium channel. Now, why would that be the cause? Because you have very high concentrations of certain local anesthetics. Like, normally we inject 1% lidocaine, not a problem. Never seen an issue with it. But when you use 5% lidocaine, you can cause nerve damage. You give enough concentration, you will have enough molecules to push themselves into the middle of the actual sodium channel and may actually cause irreversible inhibition of that fast sodium channel, which then basically destroys the activity of that axon. And it's permanent, unless you regrow them, which for some reason the axons don't seem to want to do. So one of the big concerns you have is that you do have some neurotoxicity with local anesthetics, and that may be the main mechanism. So sodium channels are inhibited. The sodium receptors has the affinity for the charged or the ionized form of the local anesthetic only, which is kind of peculiar. For the local anesthetic to cross through the actual lipid membrane, it must be formed it goes to an unionized state first. Once it goes into its unionized state, then it crosses across into the lipid membrane. Once it gets into the axoplasm, it gets reconverted into an ionized state. That's how it actually will work then. The ionized state will then come in and then bind to either one of the two sites. Either binds to inside the cell, inside the sodium channel, or on the outside, on the posterior aspect of it, and causes the sodium channel to be inhibited. So you must take that into consideration, that if you have situations where the cell area around that cell is actually acidic, the local anesthetic will not work. In acidic environments, the actual local anesthetic stays ionized, just like it does in your commercial preparation. And because of that, it won't bind to won't cross over the lipid membrane, and it won't work. Things like perfect examples of people that are that kind of problem are people that have renal failure, that are in chronic metabolic acidosis, patients that are in metabolic shock, people that are in sepsis, people that have infections in the surrounding tissue. All these lead to more of an acidic milieu around the cell and causes it to stay ionized. Now, the local anesthetics may actually interact with ion channels from within the lipid membrane. That's what I was explaining to you before. That's what we think maybe causes the toxicity. Some of the drugs are small enough that they don't seem to cause toxicity because what happens over time is they get flushed out. Example of that is benzocaine. It appears that benzocaine doesn't really inhibit from the inside, the cytoplasmic side of the sodium channel, but actually embeds itself inside the channel itself. But the good thing is it's a fairly small drug, so it gets washed out and it doesn't become a problem. Now, one of the things that we talk about quite a bit when we're doing local anesthetic is we talk about this concept called minimal blocking concentration, which is equivalent to MAC. I wish it was perfect, and I wish we could talk in more detail about it. There's still a lot of people in anesthesia are trying to say, well, can we come up with something that we can say, well, how much volume should we give in this individual? What's becoming over time is that it's becoming more prescriptive. In other words, we're just basically saying, this is how much volume you should expect to need to block these nerves. What we've been finding rather interesting is that if you look at the literature almost 20 years ago or 15 years ago, the amount of local anesthetic that we would inject would be really high. Nowadays, we're down to 20 cc's, 10 cc's, and we get the same effect. The reason the difference is before we were injecting blindly. We were using nerve stimulators, or they were using paresthesias, and they were just giving enough local anesthetic into that area. They were just in close enough proximity that a local with high enough volume will work. Okay? But the problem with it is you get more toxicity with it. Okay? So what we have nowadays is we use ultrasound, so we see where we're going, and literally you can watch the needle go in as you're actually penetrating the skin. So it's pretty neat. And as a consequence, we use a lot less anesthetic, and we get a lot less toxicity associated with it as well. So what minimal blocking concentration is basically the lowest concentration of drug that is needed for blocking impulse propagation. Things that we know that affect or increase this actual value will be increased nerve fiber diameter. So the greater the diameter, the more difficult it is to knock out the nerve. And we'll talk about that in a minute, how it actually changes. You can actually do what's called a differential block. The other thing that it will also increase it will be the increased myelination. And the greater the distance between the nodes of NVA will also increase the actual dosage. As for decreasing the dosage, things that increase your teacher pH, so if you alkalize the solution or the area around it, you'll become more unionized, and you get better penetration of local anesthetic. The other thing that's kind of a cool thing, which is the book doesn't sort of play up very much, and I do play it up right now, is that if you want something to really set up fast, you can do a really little trick. It's really simple. And you basically can increase nerve stimulation. Now, when you read that in the book, what does that mean to you? You're like, I don't know what that means, right? Well, what it means is just take that person's hand, put a little tennis ball in their hand if you're doing an interscalene block, and make them squeeze the tennis ball. It makes the sodium channels open and close when you're doing that. And you're getting sensory information as well as motor because you're having the ball in that person's hand. Okay? And you'll see that the sodium channels, because they stay open more, then the channels can be blocked more effectively by the local anesthetic. And it really makes the onset not only be more profound, in the sense of potency, will be much more dense to block, but the onset's much more rapid. So it's one of those good little tricks. If the surgeon just came out because he forgot to sign the patient, and now you have to rush back to the operating room after you put your block, and you need it to set up quickly, that's one of the things that you can do besides adding bicarb. Pregnancy also decreases your CM. And also elevated temperatures increases the velocity of molecules moving around, so it tends to give you a much more rapid block with less concentration. So let's look at differential blocks. Differential blocks are really kind of a beautiful thing about anesthesia in the sense that certain drugs are have a good ability to, you can pick which kinds of nerves you want to block. There's some drugs that don't have that. You have to have enough potency to be effective to do differential blocks. So drugs like bupivacaine that are pretty potent can do this. But drugs that are very non-potent, like lidocaine, are terrible differential blockers. And so when we talk about differential blocks, we're really talking about a drug like bupivacaine. And the reason that you can get a differential block is because the nerves inside your, the axons within your nerves have different diameters. If you look at A fibers, they can be broken down into A alpha, A beta, gamma, and delta. A delta is something that you should know. That's your motor. Beta, and then C cells. And the C-type fibers are the thinnest, and the B fibers are in between the A and the C. It's basically separated based on diameter. This is a typical example of what you would see. If you actually look at it under microscopy, you can figure out which one you're looking at. Now, why the difference in axons, right? Well, because it's like taking something and wiring it. Okay, if you want to carry very fast electrical signals, you want to myelinate it. So if you want to do motor, you want to wrap it in something very heavily with myelin so you don't lose any of the nerve signal. And you want a big enough diameter so the electricity can go through very fast. Versus other stuff, you don't need that. You can just get sensory information of somebody touching you. It's not really an emergency. You get small little fibers that come back. Or you can use autonomics or in between. So you have different nerve fibers for different activities. So what does the A alpha things do? They're the largest. They're between 15 and 20 microns in diameter. They're all mostly myelinated. They have the fastest conduction velocity. And they're responsible for motor function and proprioception. And they're actually the most difficult to block. When you look at your A beta and gamma, they have similar diameters between 4 to 15 microns. They're responsible for motor function, touch, and pressure sensation. And the gamma fibers are responsible for reflexes. And then the A delta fibers are the smallest in diameter, and those are the ones that actually provide pain and temperature sensation. So your A alpha, which is your alpha motor neuron, that's what we talk about, is the one that's coming from the ventral horn. That's the one that travels to the individual muscles that cause contraction. So you can actually separate this out. The first three are due to motor, some are proprioception, and some touch. But the A delta is purely pain and temperature. If you look at your B fibers, they're smaller in diameter. They're usually at 4 microns. They have slower conduction velocity, and they're less myelinated. They constitute the preganglionic autonomic nerves, and they're actually blocked pretty quickly by local anesthetics. The C fibers are the smallest, and they are unmyelinated. They have the slowest conduction velocity, and they conduct pain and temperature, and they're the second fibers that be blocked along with A delta fibers. So if you have a differential block, you can basically notice that the autonomic function can be blocked first. So the B fibers are knocked very effectively when you inject local anesthetics. And one of the things that you will notice when you do, let's talk a lot about interscaling blocks today, because I sort of want you to know this over and over again because it's one of the good examples. When you inject an interscaling block, if you check the temperature of the hand on the side that you blocked, if it's going to be effective, immediately you will notice that the temperature begins to rise. We used to put thermistors on people's hands on both sides, and we would measure the temperature. As soon as the temperature started going up, we knew we were going to have a good block. The faster it's set up, the better the block's going to be. Because it's the first thing that knocks out is the autonomics. So when you knock out the autonomics, what happens to the veins in that side? They vasodilate. So if you want to start an IV in somebody, you can put a block in somebody with, of course you can't, but you could put in the best IV on that side. It would be very dilated. It's actually very noticeably different too. But it also brings with it heat. blood brings heat, so that warms up the skin. So that's another way you'll see that the blocks can be effective. The next thing that knocks out is pain. Touch is a little bit later. Pain and temperature are the more sensitive, which is the C and the delta fibers. Okay? And touch is a little bit more difficult to knock out. The last one to knock out is the motor and proprioception, which are the alpha, beta, and gamma fibers. So those are the big fibers, more myelinated, more difficult to knock out. Now, we can actually take bupivacaine and do what's called a differential block by using different concentrations of local anesthetic. If, let's say, I only want to knock out the autonomics and I want to knock out just pain and temperature, then I would use 0.125% bupivacaine. And that's what we actually run with our epidurals. Our epidurals are running 0.125% bupivacaine when we're sending patients to the floor. They can walk. These people are walking around pain-free simply because we have a differential block. What it doesn't cover is it doesn't cover necessarily touch, it doesn't cover proprioception, and it doesn't cover motor. If you go up to the next level, which is 0.25, it blocks the autonomics, it blocks the pain, and it blocks the temperature, but still, not touch, proprioception, or motor. Now, I personally, when I finish a case, when I'm putting in an epidural for somebody for postoperative pain, and we did it like a AAA, and that person, and they heparinized the patient, but everything went fine. I never dosed with 0.5% Marcaine. I dosed with 0.25%, because I want to see if the person has no pain but still moves her legs. That's a good thing. If the case is finished and the patient comes out and he says, "I'm not having any pain," but he can't move his legs at all, you got a surgical emergency on your hands. Okay? Because if you use 0.25, you have most likely an epidural hematoma. That person has compression and now lost their motor horns. Unless, of course, you injected it into this subarachnoid space and you made it a spinal instead of being an epidural. So, because that alone, that's a good, helpful thing to do clinically. If you use 0.5%, basically you knock out everything, and that's what you use for isolated procedures, just using an epidural, such as C-sections. You're doing a hernia repair or something with an epidural. You can do it with a 0.5% Marcaine, and it works. You do total knee replacement, hip replacement under that, not a problem. Okay? If you don't use a 0.5%, what will happen is a person will still have touch. They'll feel it, okay, that for somebody's touching them. It won't hurt when they make the incision, but they'll freak. Some people will completely freak out, and they'll lose it, and you'll have to put them to sleep, okay, unless you can change the block density, which is difficult to do once you start giving a lot of 0.25% Marcaine. Here's the actual, I put this in for you for help you study, just to give you an example of what gets blocked first, which is the autonomic, preganglionic sympathetics, followed by the C fibers and the A delta fibers, and then third is the A alpha and gamma, and the fourth one is the most difficult one, is the A beta, which is sensory touch and pressure. That's why it's a little bit difficult to knock those out. Now let's look at the chemical structure. The chemical structure of local anesthetics is that all local anesthetics are weak bases, but they all have significantly similar chemical structures. They all have a aromatic group on one end, they have an intermediate bond, and they have a tertiary amine. The tertiary amine is what gives it ionization. Okay? And the aromatic group is the lipophilic side of it, which is the lipid-soluble part of it. So that's the side that will penetrate more into it. If you make the molecule less charged, the more lipid-soluble it becomes. Now, why do I make you learn this? Because your C exam, your not only C exam, but your certification exam now has this. They will ask you, where is it that the local anesthetic is named? How do you know if it's an ester or an amide? Okay? Esters were the first local anesthetics. Esters are cocaine. Esters have no I in the name ester. Okay, so if you have a local anesthetic with no I before the cane, it's an ester. That's how you remember it. On the other hand, amides have an I in the actual name. Okay? And all amides have the local anesthetic is named with an I in it before cane. So prilocaine, bupivacaine, okay? Ropivacaine, lidocaine. All those are amides. Okay? Things that are not amides are cocaine. Those are esters. Procaine is an ester. Tetracaine is an ester. All those, just by looking at the name, you know what they are. Now, what they did on the actual exam, apparently, is they make you identify where, if it's an ester or an amide. So I have to explain to you what an ester or an amide is. Okay? If you look at an ester is a COOH group. The book's got it wrong. The book says it's a CO group. It's not. It's a COO group. Okay? It's a carboxylic acid group, okay, which is what this is. Okay? So its ester is this. Okay, COO. Versus an amide, the way I remember it is, what's the letter right after M? N, which is, it's got nitrogen in it. Okay? So amides have nitrogen in the intermediate group. Okay? So it's the NCOO group in it. And that's how you pick out that that's an amide. Okay? So amides have N's in them. Okay? How you pick it up. Now, this classification of esters and amides are actually pretty helpful because it tells you the characteristics of the drugs. When we talk next week about neuromuscular blockers, I'll do the same thing. We'll talk about benzoyl-isoquinolones versus aminosteroidals. But drugs like local anesthetics have two family groups, esters and amides. And esters have a lot of toxicity in comparison to amides. Okay? So the linkages that you sort of want to memorize is the esters have the COO, and the amides have the C double O bond and the nitrogen on it connected to it. And that's what actually makes it metabolize different. Anytime you have a carboxylic acid group in something, it readily hydrolyzes. In other words, that's where the cleavage point works. The medication breaks right there, okay, because it's able to be hydrolyzed. So if you look at the properties of these two things, if you look at the metabolism of amino esters, they're rapid by plasmacholinesterase versus the amino amides, because it has a nitrogen in it. They don't break easily. It takes liver enzyme to do that, P450s to do that. So it's slow. Systemic toxicity is less likely. With the amides, it's more likely because it doesn't get broken down, but you get a lot more allergic potential with esters. Esters break down into what's called PABA, which is para-aminobenzoic acid, and I'll show you a picture of it in a minute. And that has a lot of allergic potentials, especially on repeated doses on individuals. Amino amides, and this is what makes it very safe, is that it's very, very rare to have an allergic reaction to an amide. Dentists still use a lot of esters. Novocaine is an ester. The problem with that is that they see a lot of allergic reactions. And then people come in and say, well, I'm allergic to local anesthetics. Then you got to sort of figure out, what did they give you? Which local anesthetic are you talking about? And most likely, if it's a dentist, I'm telling you, it'll be an ester that they're allergic to, which is they're allergic to the para-aminobenzoic acid. So that person is perfectly safe to give an amide to them. It is totally safe to give bupivacaine, lidocaine to a person like that, because that almost has zero reactivity to allergic potential, and there's no cross-reaction. If you look at stability in solution, esters break down in ampules very quickly due to heat and sun, versus the amides are actually very stable. Again, that makes them a little bit preferable drug choice. The onset is slow with the esters, and the amides are actually pretty fast. And the pKa's are higher than pH. It's about 7.4, but it's close to pH with the amides. So it makes them a little bit more 50-50 in this ionized state to an ionized fraction, so it makes it a more rapid onset. Once you look at the chemical structure, you basically can change different things to increase lipid solubility, potency, rate of metabolism, and duration of action. I put in here all the drawings of all the different amides and esters that we normally use. And I want you to pay attention to these different changes that we're going to make. What I'm going to do is we'll start with, let's look at procaine. Procaine is a top molecule here in green. What's going to be made different about it is that we're going to add what's called butyl acetate. Okay, butyl acetate will be cleaved and will be incorporated into the end of the molecule here. Okay, so here's where the actual molecule gets incorporated. And when we do that, we call it tetracaine. Just that simple addition will make this thing become much more lipid soluble. And when you increase the lipid solubility, it becomes 10 times more potent and has a much longer duration of action. And simply by changing that little bit, decreases the rate of metabolism as well. If you look at procaine to chloroprocaine, it's a very minor change. What you're doing is you're halogenating the procaine. You're adding a chloride group to this. So this is the molecule that you've added. You've added a chloride group. Okay? And when you do that, you actually make the molecule more rapidly metabolized. It gets hydrolyzed much more readily by the plasma cholinesterases. This limits the duration of action and decreases the toxicity of chloroprocaine. So what you look at it is, if you look at the wording carefully, it's procaine with a chloride group. That's why it's called chloroprocaine. That makes sense? Now, lidocaine is, on the other hand, is an amide. This amide can be converted into a derivative called etidocaine. Etidocaine, the way it's produced by adding ethyl groups at the amine group and the intermediate chain, and that really changes the molecule, the way it functions. What the actual ethyl group looks like is this, and you're adding it here and here. So the two areas you're adding it to it. And when that happens, you increase the lipid solubility of the agent, and you increase the duration of action. And the onset speed of this medication is pretty fast. The downside to it is it has a little bit more toxicity, as we'll talk about a little later. Then you have what's called the pipocolloxylides, local anesthetics. And what makes these local anesthetics unique is they are all chiral molecules, which means that they have stereo isomer views of them, which means that they have two molecules with mirror images of each other. Why is that important? Because it's like when you're giving these drugs in the racemic forms, which means that they're 50-50 in R and S forms, it's like giving two different drugs. They will not work the same. And one side of the drug will be toxic, and the other side will be okay. And that's what we see with bupivacaine. Mepivacaine works okay in a racemic fashion. And bupivacaine also goes in as a racemic fashion. And we find that the R component is very toxic. That's what causes the problems of the heart. It's the cardiotoxicity component. So what we have done chemically is we've converted or eliminated the R group and changed the medication to call it ropivacaine. Ropivacaine is very close to bupivacaine, except it's slightly changed where you remove all the R enantiomers, and as a consequence it has supposedly less cardiac toxicity. The other one that also has been specifically designed, which looks just like bupivacaine, it is bupivacaine, except it just says the S enantiomer is levobupivacaine. Levobupivacaine is the S, L for left. That's what S stands for. S is, do you know why it stands for? Sinister. Sinister people were left-handed people. We were evil. I'm evil, so what the heck? I'm an evil professor. Okay, so this is the piperidine group. Piperidines are what you add on this end of it. Okay, piperidines are familiar to you, right? What other molecule has this? Fentanyl. All the synthetic narcotics that are Demerol associated have piperidine groups, which is it's kind of cool. It's like it seems like it's one of those things required to sort of bind to a receptor more effectively. This adds a lot of potency to this drug. So all these drugs are potent. Let's go into pharmacodynamic principles and pharmacokinetics. I'm going to this as I get moving along. Local anesthetics are weak bases. The pK values are very close to the physiologic pH. So usually that means that 50% of the local is ionized. When you decrease the tissue pH, results in a more ionized local. You get less tissue absorption, poor quality anesthetic effect in patients at high risk for renal failure patients and septic patients. Factors that affect the onset and duration of action. There's various interventions that have been made to basically make the onset and duration of action improve. We can do what's called carbonation, which is kind of cool. You actually will take the medication and carbonate it. You will incorporate CO2 in it. We did this in the clinical area, and it sort of made the onset pretty fast. It was pretty amazing just by adding a little bit of CO2 to it. And it doesn't really have a problem with causing the medication to fall out of solution. The problem with it is that it takes a lot of effort. And clinically, it's just, you're not going to have time to do that. You have to have all sorts of special things so you don't contaminate the local anesthetic with bacteria or stuff. So it's not something we necessarily do. What we do very easily is sodium bicarb. That's readily available in our carts. So we add the sodium bicarb after we drop the local anesthetic. And we know that it decreases the latency of onset and increases the duration of action. What it basically does is it increases the pH solution, results in the drug converting into a more unionized state. And things like lidocaine and bupivacaine can be really helped by bicarb. And the biggest limitation factor is if you cause precipitation, you basically have wasted money, and that medication has to be thrown out. The other thing they've been using is they've added dextran, which actually increases the duration of action. Dextran is a sugar. What it basically does is it holds the local anesthetic for a longer period of time so it doesn't get metabolized, and then slowly lets it extrude out into the surrounding tissue and has a longer duration of action for that reason. The other thing that is important is vasomotor activity. Unfortunately, most local anesthetics that you use are going to cause vasodilation. The only two exceptions to that are cocaine, which is a vasoconstrictor, and mepivacaine, which doesn't have any effect on the vasomotor tone. That's the exceptions to the rule. Okay? Cocaine will vasoconstrict. If you inject it into mucosa, you will notice that it'll blanch. I'll show you pictures of what blanching is in a minute. And the mepivacaine won't change the tone at all, but all the other local anesthetics will cause hyperemia, which the mucosa will actually increase in blood flow. So if you inject local anesthetic like lidocaine directly into the mucosa, the bleeding will actually increase, not decrease, which is not good. So what we have to add to it is we add something else, which increases vasomotor tone, which would be things like epinephrine, which is the most common one that's used. It results in an increase in blood to the area, and what increased blood does to you is it extracts the medication from the tissue you just injected, which is what you don't want. Because you want the medication to sort of sit there and work if you're doing topical infiltration. So that redistributes the medication and it eliminates its activity. So this is an example of lidocaine has more vasodilation than prilocaine, and of course mepivacaine has none. Bupivacaine and nitidicaine are very similar in the sense they both cause vasodilation, and nitidicaine is a little bit less than lidocaine, so that puts bupivacaine a little bit less than lidocaine as well. The effects unfortunately, of absorption is it increases systemic toxicity. If you get more absorption, the more toxic it's going to be. So it depends on the total concentration of the drug, total dose, which is concentration and volume dependent. The area in which the local anesthetic is also applied is important because the greater the blood flow to that area, the more the effect's going to have. So what I have to have you memorize is the following, because they ask this all the time. The tracheal has a high blood flow area, so because of that there's a high absorption rate and a much greater toxicity associated with that than compared to subcutaneous. When you see the surgeons injecting the local anesthetic in the subcutaneous tissue, it's actually the safest place they can inject it at. Okay, it is very low blood flow to that area, so as a consequence the absorption rate is pretty slow, so toxicity is still minimal. Now it doesn't mean that it's zero, okay, because you still can get in trouble. I got a phone call when I was in the OR on Saturday morning by one of our surgeons, and he said, I don't feel well, And I was just wondering what you thought about this. And I said, what do you mean? What are you doing? And he said, well, I'm in my office, and I'm taking off a mole off my skin, and I've just injected about 50 cc's of local anesthetic into my leg. And now I'm starting to feel kind of faint. Well, you're getting like local anesthetic toxicity. So you still can reach threshold and cause problems. So just because it's subcutaneous doesn't mean that you can't get in trouble. So what we did is we ran over to his office, picked him up, and brought him over to the recovery room and watched him for about 2 hours, and then he was fine. But he looked like he was in a Caesar for a little bit. Now this is what blanching looks like. You can see the woman's skin down here is normal. This is what happens when you inject epinephrine, when you what you call tumescent local anesthetic. What we do is we inject large volumes of local anesthetic into the subcutaneous tissue, and that decreases the blood flow so they can do liposuction. So epinephrine is the agent of choice that causes this vasoconstriction, and it helps keep the concentration of the drug at the site of action, which results in a much longer intense block and less systemic toxicity. All right, so when you add epinephrine, what you're basically doing is you're vasoconstricting the blood vessels, and you're locking in the local anesthetic to that area. And hopefully what you're going to do is you're going to prolong the duration of action. And this is can be done with when you use agents like procaine, mepivacaine, lidocaine, especially lidocaine. It's the addition of, because it's so lipid soluble, it really increases the duration of lidocaine. Usually enhances it by about 30 to 40 minutes. On the other hand, epinephrine prolongs the duration of local infiltration peripheral blocks, but not in all medications. If you use bupivacaine, it still works at the local level, but when you use it at the epidural level, it doesn't really make a difference when using procaine, bupivacaine, or rotidicaine. Those medications do not increase the duration of action in the epidural space. So epinephrine has been proven to be basically the most effective agent to vasoconstrict, and usually the concentrations that we use it at is 1 to 200,000, which is basically 5 mics per milliliter, and that's our normal dosage. Now, this distribution is actually a pretty important factor of how local anesthetics work. When you inject them, you're trying not to inject them normally into the bloodstream. There is certain kinds of blocks that you will inject it directly into the bloodstream, which is a typical example. That's a beer block. But the safety of the beer block is that you have to have a tourniquet that works properly. When you inject the local anesthetic into the vein, the local anesthetic then penetrates from the high concentrations in the vein and then goes into the tissues where it then depots. And the tourniquet will keep the medication going into the tissue. As soon as you release the tourniquet, the concentration in the blood is going to drop off very rapidly, and then the medication is going to basically redistribute from the area where you had the tourniquet on back into the rest of the body. So the first place that the local anesthetic is going to go is if you inject it intravenously, it's going to go to the high blood-rich groups, so like the brain. The other thing that it goes through is it goes into your veins. If you inject a medication like bupivacaine, a big part of it actually depots in the lung. Okay? The lung extracts a big portion of local anesthetics as they travel through your bloodstream. Eventually it does get to the brain and then redistributes after a while to other areas such as muscle and eventually into adipose tissue. The problem with the danger of local anesthetics that get into your intravascular system is because it does have very high affinity for the brain. So it causes CNS toxicity. And I've had that happen to me one time. A person seized right in front of me. And I could have sworn there was no blood. I aspirated back every 5 cc's. I was a little bit in a rush, but not that much. And I was aspirating back every 5 like I was supposed to, and I still got a seizure. Okay? Because I just didn't pick up that it was intravascular. And the person's heart rate never did really go up. Found out later on, when I looked more carefully, the patient was on a beta blocker, and that's how I missed it. Stupidity. Sometimes you make mistakes. But she ended up being fine, so just chalk it up as another thing experience, Just be more careful like you always, and that's what you want to be. Eventually what eliminates the medication is metabolism and excretion, which is the red line here. It begins to metabolize a big portion of the medication. The big problem with amines is that they're metabolized by the liver, and it takes longer for that. So if you the one that's going to cause you more toxicity is the amides in comparing to esters. The downside to the esters is that the metabolism, which is hydrolysis, converts it into a medication that's allergic, which is paraminobenzoic acid. So the esters are not your friends either. Onset of action is dependent on lipid solubility and state of ionization. The most important of these two is state of ionization. The charged molecule will not penetrate as well as the uncharged. So what you want to have is drugs with low pKa's, which means that it'll be less ionized at physiologic pH, and therefore have a shorter onset direction of action. So if you look at all these medications, which are all amides, they all have pKa's more into the physiologic range. They have their pKa's at 7.9 to 7.7, and 7.6 being the lowest, which is mepivacaine. And all these have very rapid onset of action because of this value. So when you look at a medication and you look at their pKa values, that will tell you the duration, the onset time. The lower the pK, the faster the onset for a local anesthetic. Now, there is an exception to rule, and I should get to that eventually later, but there is exceptions. Now, clinical situations, the decrease of pH at the site of injection will result in a slower onset, so acidosis, infection, or abscess formation. We talked about this like 3 times. So I think that's pretty important. I said it 3 times, so you can expect at least 2 questions or maybe 1 question out of the test for this. Now, what ionization will tell you is you're looking at the pKa values, and you can see the relative onset of action. All the values except fluoroprocaine, which is pretty high pKa, is fast onset. Why would that be the case? Because it's very concentrated. When you inject fluoroprocaine, it comes in 3% solution, which is very high in amount. So for that reason alone, you increase the number of molecules. And we talked about how it's lipid solubility, but it also could be concentration dependent. So for that reason, it's fast onset. All the other drugs that have pKa's above 8 are moderate to slow onset. Okay, bupivacaine is a moderate to slow onset. Now, the potency of the drug is telling you how long, not so much how long, but how strong the effect's going to be. Okay? And if you look at it from the standpoint of how nerves get knocked out, it's the numbers of them that get knocked out. The more potent the agent, the more likely you're going to knock out the motors. The less potent the agent, then the less likely you're going to knock out motor, but you'll still take out the temperature, pain, and autonomics early. Okay? So just because something's not potent doesn't mean it won't work. It just means that if you start causing a lot of deep kind of pain or touch experience for that patient, it may break through and cause problems for you. And when you equivalent to look at that value, what actually gives you an idea what potency is, just like when we talked about volatile anesthetics, is the actually partition coefficient. In this partition coefficient, we're looking at the oil to water partition coefficient, which is over here on the side. The partition coefficient at the end of this table will indicate to you what percentage of it will go into oil, which means that it's more lipid soluble. So the higher the number, the more lipid soluble it is, and usually the more potent the medication is. So if you look at this table, bupivacaine, which has a partition coefficient of 27.5, has a very high potency. Etidicaine, which has a very high partition coefficient, is also very potent. Things that are not so potent are things like lidocaine. Lidocaine only has a partition coefficient of 2.9, and actually in the potency ratio scale of 1 to 5, it's 1, so it's pretty weak. So when you look at, this is a different graph. This goes 1 to 10, so everything is slightly different. So just be aware which graph you're looking at. Every book's got it a little bit different. That's why I show you 2 different ones. This still shows you that the greater the partition coefficient, the more potent the medication tends to be. Okay? Now, the duration of action is something different. Potency means how rapid and how deep the medication will penetrate, which is lipid solubility. Binding is what makes the local anesthetic work. It has to bind to the sodium channel, which is a protein. So something that is very protein binding okay, high protein affinity, will have a long duration of action. Okay, so how do you measure that? You can look at the protein binding number for that, and that will tell you pretty much what the medication is doing. So what you look at is the protein binding number here. You can see anything over the 90s has a long duration, usually over the 80s, sorry, has a long duration of action. So tetracaine, atidocane, bupivacaine, ropivacaine all have high protein binding rates of over 80, and as a consequence, you have long-acting effects. What's interesting about the protein binding is it's always associated, or tends to be more associated with high lipid solubility as well. So you can see these agents that are very long-acting tend to be also highly lipid soluble. The short-acting ones tend to be poor lipid soluble and have low protein binding. So let's go on to the next step, which is metabolism. We're going to go into metabolism of esters first, because those are the medications that first came onto the market, like cocaine and then Procaine. One of the limitations of these drugs is that they have very short durations of action. If you work in a dentist's office, that's actually a good thing. If somebody's going to put Procaine in your mouth, that's not a bad thing, because they inject it into you. It works for 45 minutes. They extract your teeth in 5 minutes, and then you're basically numb for 30 minutes, and then it starts going away, and you start feeling better right away. You don't want something long-acting where 8 hours later your mouth is still numb and you can't eat. Okay, it's pretty uncomfortable. So the short-acting esters are actually pretty helpful in that sense for dental work. What esters are is they're hydrolyzed by pseudocholinesterase and cholinesterases in the blood. The primary one is the ones found in the plasma. So plasma cholinesterases are the primary metabolic route by which these medications get broken down. And what you get is also red blood cells, and liver also are important. As part of the hydrolysis reaction, which means that you cleave it at the COOH group, you basically break the aromatic ring of it, and you leave behind this COOH NH2 group with your benzene ring, which is called para-aminobenzoic acid. The benzoic acid is the COOH group. That's what makes it the acid. It's responsible for a very high incidence of allergic reactions associated with esters. So when you hear PABA, that's what they're talking about. And PABA is found in a lot of skin products too. So if you've been exposed to that and you form an allergic reaction to it, when you get injected an ester, you get a very profound allergic reaction that can be very dangerous. The rate of hydrolysis is fairly important. Chloroprocaine, because when you add the extra chloride, you make it more likely to break down by the plasma cholinesterases. Procaine second, and tetracaine is the least likely. And when you talk about toxicity, which is different than allergic reaction, tetracaine is more toxic than chloroprocaine because it doesn't metabolize. So the plasma half-life for procaine and chloroprocaine is less than 1 minute, which is pretty fast. Where you might see a problem would be somebody who has cholinesterase deficiency. So somebody who has pseudocholinesterase deficiency, if you give them an ester, they can get into the toxic range pretty quick. Tetracaine has limited clinical use because of its toxicity in high concentrations. Where we use tetracaine is we use it in spinals. If we want long-acting spinal one of the limitations of it is it takes a little bit of time to set up. But once it sets up for a long period of time. The other concern is that tetracaine is also an ester, so it has to be broken down to be inactivated. Well, tetracaine can't be broken down in the CSF because there's no cholinesterases in your CSF. So the way the medication actually stops its action is that it has to diffuse out of the CSF into a blood vessel, which then it gets reuptaken, and that's when it gets broken down. So tetracaine can have a very long duration of action for that simple reason. Factors that affect ester metabolism are things that affect plasma cholinesterase. So if you can saturate the plasma cholinesterase with another molecule, such as succinylcholine, and then you follow it with an ester, you may get into trouble. If the plasma cholinesterase is already inhibited or it's genetically not typical, you may have significant prolongation of effects of the esters, and they can get into the toxic range and give that person more problems. And in certain forms of liver disease where you don't produce the plasma cholinesterases, you get more prone to toxicity. But clinically, we've seen that procaine and chloroprocaine, because it's so fast metabolized, you usually don't see that problem. It's more the tetracaine that you get an issue with. Yes? Okay, cholinesterases are found in your bloodstream. They're a byproduct of the liver, okay, and it excretes it into your bloodstream. So it acts like an active metabolic factory that's sitting there in your blood to break anything down that you might have ingested, okay? It's basically a safety factor that the body puts in place to prevent from you ingesting material that may be plants. There's a lot of plants that have cholinesterases in them, okay, or choline-like molecules. And if you drank those or ate those, what would end up happening is it would affect your neurotransmitter sites. It would begin to mimic acetylcholine or have like that kind of effect. So cholinesterases cleave those before they get to your sites. The acetylcholinesterases that we talk about are at the nerve endings. Their job is to take the endogenous, naturally produced acetylcholine and cleave it. So they're not found in the blood. They're found at the nerve endings. Different function. They're similar, but they're molecularly very different because one's bound to the cell wall versus the cholinesterases are freely floating little enzyme factories that do what they do. Not really. Succinylcholine is really going to be affected by plasma cholinesterases because when you inject that medication, 80% of what you inject is broken down before it gets to the actual neuromuscular junction. Okay, so if you don't have any plasma cholinesterases, or if you have atypical cholinesterases, the succinylcholine levels will go sky high on you, and you'll get more binding effect. Okay? If you give a reversal agent to somebody, let's say you give you can give them acetylcholinesterase inhibitors, which you knock that out. Succinylcholine doesn't really get metabolized any different. Okay, so it won't really help push off the medication any better. What it basically does is it increases acetylcholine enough that if you're in a phase 2 block, it may actually help push the medication off. But that's a different kind of situation. I'll show you that in the next week when we talk about neuromuscular blockers. Okay? Not next week, but the week after that. Okay. Metabolism of amines is a little bit different. These are metabolized by the liver. It's a hepatic enzyme activity, so it's a P450. And it's also hepatic blood flow dependent. So if you have liver disease or you don't have enough of the P450 or you have inadequate blood flow, congestive heart failure, then amide local anesthetics will not be metabolized properly, and you can get into the toxicity again and cause problems. The good thing about amides is they have very, very, very low allergic reaction rates. And if you do see an allergic reaction to an amide, it's usually due to the preservative that's with the solution. And that's why I'm always very careful about reading what the preservative is on the anesthetic agent that I'm using. The rate of metabolism is slowest to greatest, with bupivacaine being the slowest and lidocaine being the fastest. You sort of need to know the lidocaine's in the between. Clearance is independent of potency, lipid solubility, protein binding, or chemical structure. So it really depends on metabolism for that clearance to take place. You must convert this medication, and it's complex. The book started talking about the actual metabolism of individual. I said, you know what, this is a little too much. I already have enough. I have 103 slides for you already. I think I can add another 20 in doing that, but I don't think I need to add that right now. Pregnancy, one of the things that we see is that women that are pregnant have a higher sensitivity to local anesthetics, and as a consequence, you need to consider that. You need to reduce your dosages where it's not so much different as the epidurals, but with spinal anesthetics, definitely decrease your dosage. And we think it's hormonal changes, such as progesterone levels are very high. They may actually be binding to the same sodium channel and actually enhancing and decreasing the actual sodium propagation. So we think that that's one of the major reasons that women develop forgetfulness, and also they increase their sensitivity to local anesthetics. Now, the maximum doses is something you're going to have to know, unfortunately, because it's something that is always asked in clinical. The problem with it is that there's no studies have ever been done. All these are anecdotal. They've been sort of correlated to what animal things are done, and then you see some things in a clinical where you see a person sees, and there's so many variables when you're looking at Tmax that what I would do is I would always stick on the conservative side. And because you still have case reports of systemic toxicity that even a person has not exceeded the maximum dose. It sometimes has to do with looking at lean body mass, not looking at total body mass, which can fool some people. If you're you should lose, most of the time you should use lean body mass, not total mass for injecting local anesthetics. Okay, but there is no human studies which indicate severe toxicity, but you know it. So, prevention of toxicity is pretty clear. You can do it by giving people benzodiazepines beforehand. So when you give benzos before you do a block, you're actually helping protect that person's brain. What you're doing is you're giving that person a GABA agonist, which will suppress seizure activity, okay, which is a good thing. Okay? So it helps prevent the CNS toxicity of local anesthetics. What I would recommend you do is use drugs that are safer, like lidocaine, prilocaine, and chloroprocaine, produce limited toxicity due to short distribution and elimination. Bupivacaine is more dangerous to use, especially if you're using high concentrations of it. And I would never use 0.75% anymore in my practice. That's been eliminated in my practice. Some people still use it, but I think it's very, very dangerous, especially when you see somebody cardiac arrest on you. You got to be vigilant. You can't just sort of blow this off. Remember I just told you the story, what happened to me? I was still being vigilant, and it still happened to me, even though I was aspirating. You can never tell sometimes if you're intravascular. And then the patients on beta blockers, you're not going to pick up the increase in heart rate with the actual epinephrine that's added to your solution, which is pretty much what you should do all the time, is you should add epinephrine to your solution to look for increases in heart rate to pick up that the person is getting intravascular injection. I always talk to my patients when I'm putting the block in. I repeatedly keep asking them, how you feeling, how you doing, and I'm trying to measure response rate. If all of a sudden the response rate drops off, that's how I picked up that this person was going to get in trouble. I already given 15 cc's at that point, and the person didn't talk to me anymore, and I stopped injecting. And I said, what's going on here? And I started talking to her, hey, come on, wake up. And all of a sudden she started seizing. And that's how I picked up on it. Otherwise, if I wasn't paying attention, I would just kept injecting the 30 cc's that I wanted to inject. And that would have really been bad. Okay, so, because it was bupivacaine. So the good thing is you just seized for a few seconds. We just supported the airway. She was breathing. The seizure stopped pretty quick. Because redistribution, that's what saves your butt on these things, is redistribution. The stuff comes off pretty quick. And then the person stops seizing because of the hypercarbia, which also adds to it. There's limited local anesthetic dose based on site of injection. You want to just give enough to work, but not, and be careful if you're injecting multiple sites for concerns of overall dosing. Watch for the person who has advanced age, poor cardiac function, ischemic heart disease, cardiac conduction abnormalities, or metabolic, especially mitochondrial diseases, because some of these local anesthetics will inhibit mitochondrial function, and also abnormal low plasma protein concentrations will, because you have high protein binding, these medications, if you don't have low proteins, you may actually get a much more toxic effect as well. This I can't teach you enough. Aspirate syringe prior to each injection, and I do it every 5 cc's. It's religious. I watch people sometimes go crazy. I had somebody one time take an epidural, and they said, oh, I got a perfect epidural, and then just gave 20 cc's, and I'm yelling at them, what are you doing? And sure enough, it was subarachnoid, and 10 cc's got in before he stopped, and all of a sudden we had a high spinal. You can't do that kind of stuff. 5 cc's, wait 30 seconds. 5 cc's, wait 30 seconds. 5 cc's, wait 30 seconds. It just keeps you safe. Okay? What you'll do is you'll pick up on it. If it gets intravascularly, by, like I said, by the 10th and 15th cc, you'll start getting seizures, okay, which is what happened to me. So I was going slowly enough that I picked up on it. I didn't pick up the circumoral numbness, which I should have picked up, but sometimes you just don't. The patients are not. This was a postoperative patient. It was a little bit out of it, and that's a big issue. You don't want to knock somebody completely out before you do a block. It is unsafe. Do not use bupivacaine before you do a block. I'm sorry, don't give propofol before you do a block. It is really not smart. Because if you hit the nerve, are you going to know it? And then you're going to inject into the nerve. It should never be so painful that the person's screaming. when you're injecting the local. If you're doing that, that means you're in the nerve. Stop. Back it up. Okay? Now, well, we use pharmacological markers to identify if you're intravascular. So we use the epinephrine 1 in 200,000, which is 5 mics per milliliter. What should happen is within 30 seconds of injecting your 5 cc's, you should see an immediate increase in heart rate. The problem is a lot of these new medications that are coming are combined beta blocker with diuretic. And sometimes you don't recognize that they're beta blockers because they have some weird, new name. They got it. They have propranolol. It's not that OL group on it. So that's what you're looking for in the chart. Where's my beta blockers? And you don't pick it up because it's got like something else like Zestril, I can't remember the name of it. But there's other drugs that have combination drugs. So it's increasing our problems. Monitor the patient after completion of injection as peak blood concentrations may occur up to 30 minutes. So once you inject a block, you don't walk away from the patient. Your job is to stay with the patient, or somebody should stay with the patient. Never, never walk away. I had two students do that one year. They were so happy they got to do the interscaling block with supervision, and the attending left, and they thought, well, the attending left, I can leave, so everybody left. Well, I come back in. It's not even my patient. I look at the patient looks kind of not good. Saturation's 82%. And then what they did was they knocked out the phrenic on that person, and nobody was watching them. And slapped the oxygen on them, called the students, what are you doing? You can't walk away. So don't walk away from patients, okay, when you do blocks. You're asking for it, because it does peak out at 30 minutes. This is what you'll see with systemic CNS toxicity. The first thing the person will get is they'll get circumoral numbness. They will get then lightheaded. They'll hear tinnitus. So one of the questions I always ask when I inject local anesthetic is, tell me if you get a metallic taste in your mouth. Okay? Do you hear bells in your ears? Okay? Do you feel like your heart's racing? Or you feel like your legs go to sleep? Those are the 4 things I ask every time I put an epidural when I do a test dose. Okay? I'm looking for intravascular injection, and the numbness in the legs is to see if I got a subarachnoid block. If I have a spinal instead of an epidural. What you'll see is if you continue giving the concentration up, you'll get visual disturbances. The person will start slurring their speech. They'll start twitching, and then I'll go unconscious, and then they'll go in seizure. If you give too high a dose, then the other person will go in a comatose state, and then it'll develop apnea. What you see with lidocaine, the therapeutic level should be between 2 to 4 mics per milliliter. When you get up into the 3 mic per milliliter, the person will feel circumoral and tongue numbness. And at 4, the person will start getting lightheaded. This is the surgeon I was telling you about the other day. He was getting lightheaded. He had at least plasma concentrations of 4 mics per milliliter. Most likely he was having visual disturbances as well because he couldn't read. So he was up in the 6 mics per milliliter concentration. The next level they do is they go up in the higher levels to get muscle twitching, unconsciousness, convulsions, and coma. But you can see that there's a big rise. I mean, you have to go from literally from 4, which is therapeutic, now you have to triple it and go to 15 before you go into a comatose state, and or you can go into convulsions. So that's a pretty heavy dose. The CNS toxicity will depends on the drug potency and acid-base status. If the person is becoming alkalotic, okay, the medication will more likely penetrate into the brain. So both respiratory and metabolic acidosis increase the toxicity. Acidosis increases the toxicity of the medication, and alkalosis decreases the toxicity of local anesthetics. Now, elevation of carbon dioxide tension leads to cerebral vasodilation is the main reason, because it results in more drug delivery to the brain. So it's not so much the ionization, but rather the amount of drug being delivered to the brain. If you hyperventilate that individual, blood flow decreases going to the brain, and as a consequence, you get less medication getting there. The problem with it, though, is if now you're reversing, you're making the molecule more unionized. So that can overcome the system even though you have lower blood flows. I personally think that's dangerous. I don't like to tell a patient to hyperventilate as I'm doing a local anesthetic block, because the reason being is if he does seize, even with doing that, then I'm in really trouble, because the duration of the seizure is going to be prolonged. It's going to stay a lot longer. What terminates seizures is hypercarbia. It's the elevations in CO2 that terminates the action of the seizure. So by hyperventilating them, now I'm giving them a much longer seizure time, and that's not fun. Okay? So acidosis causes less protein binding and more free drug available. CNS toxicity, clinicians, like I was telling you about, they voluntarily hyperventilate their patients. For the acute lowering of the carbon dioxide may also lower the seizure threshold, which is, I think, it increases the risk. Treatment, primary concern of CNS toxicity is seizures. Okay? During convulsions, oxygen consumption increases dramatically. So the initial intervention is, of course, airway management, maintain airway, and make sure that you add additional oxygen. That's why anytime you see me do a block, I will tell you, put the person on nasal cannula. Every time. And people forget that. No, they're getting a worry because they want to get a block in. No, slow down, put the oxygen on the patient, increase your safety. Okay? This is a great case the other day. In day surgery, we were doing an interscaling block. 30-year-old guy, perfectly healthy. You would never expect a problem. 1 milligram of Versed. He's doing real fine, you know. And we got the block in. He's right by the nerve. It's perfect under ultrasonography. The guy hasn't really had a lot of pain. All of a sudden, he looks up at us and says, I think I'm going to go out. And I look at him like, we haven't even injected anything. He says, well, I'm going to go out. And he was right. He went out. And he started seizing. Okay? And he went totally unconscious on us. So we lifted his airway, and students are their big eyes at that point. They're freaking out. And I'm going, just take the needle out. We pull the needle out. Just wait a few seconds, and it stopped. And we put the legs up to make sure that he was perfusing well. Checked his blood pressure. It had dropped a little bit. His heart rate had dropped down to, I think, 55, 60. We gave a little atropine, and that resolved it. He woke back up and looked at us like, what happened? It's like, well, we got to do the block again. And he goes, oh, okay. So we put the block back in. Worked out fine. But it can happen even when you're not doing anything. It's just a person vagaled out on us. So just from the electrical stimulation, we either got close to the vagus nerve with a needle, which is a possibility. So when we were stimulating, we got close to the vagus, it's running down to the neck, and that caused him to go vagal. So I really don't know what exactly happened, but like I said, things do happen. Okay, if the person starts to seize on you, maintain the airway. If you have thiopental, you can give thiopental reverse-C to stop the seizures. I use Versed instead because that's what we have readily available. If hypotension occurs and is unresponsive to conservative treatment, then consider ephedrine or epinephrine if it gets worse. Atropine can also be used for bradycardia. It must use at least 0.4 milligrams. Please do not titrate atropine. Atropine is another drug you can't titrate. Okay? You have to give 0.4 at the minimum. Okay? So what you're trying to do is you're knocking out all the parasympathetics. It's an anticholinergic, so it shuts down the parasympathetics, so that means that the sympathetics can take over. Okay? Use the ultra-short muscle relaxants such as succinylcholine. I think it's really stupid. The book says that it's a good idea to stop the seizures. Guess what? It does not stop seizures. Succinylcholine paralyzes you to make it appear that you're not seizing, but you're still seizing. Okay? So please don't believe that. That book, I don't know why they said that in the book. So do not use that medication. It's okay to use if the person is now clamping down, not breathing, and you can't get an airway open to give succinylcholine so you can terminate the muscle contraction so then you can ventilate the individual. And I can tell you, almost everybody that's in this situation usually is a full stomach, so you better apply quite good pressure and immediately intubate that individual to protect their airway. But it will not stop the seizures. So the first thing, if I was going to do this, I would give succinylcholine to break it, get the person intubated, and follow it. Once I got the airway stabilized and I got an eye on the blood pressure, hit him with Diprovan, which will terminate the seizures, or give him benzodiazepine in high enough concentrations to terminate the seizures. Because you don't know. And then when the succinylcholine wears off, the person's still twitching, guess what? They've been seizing for that whole period of time. So it is not a good idea to hyperventilate the other person either. Once you get them intubated, just go slow. Don't ventilate aggressively. You want the CO2 to elevate, okay, so the seizure terminates. Neurotoxicity is a real big problem recently. And I think personally, you have to look a little bit historically about what's going on with local anesthetics and neurotoxicity. And if you look at from the 1950s to the 1970s, most neurotoxicity was associated with re-cleaning the needles. Okay? So it was almost always due to error on cleaning the equipment. But after the 1970s, when we basically took and never reused needles, the toxicity level went way down, and it was almost non-existent for many years. We didn't see local anesthetic toxicity. And then somebody developed this really brilliant idea, which I consider not very brilliant, which is a continuous spinal catheter. I think it's the worst idea possible. When I was a resident, I was talked into doing a continuous spinal catheter in an individual. And after we were finished, this person had cauda equina syndrome, permanent. And cauda equina syndrome is not benign. You may read it in the books and say, well, it doesn't sound so bad. It's horrible. What this person actually developed was severe burning pain in their perineum, and he basically became impotent. This is a man, and it was extremely painful anytime he urinated. So to the point he was screaming every time he urinated because the nerves were so messed up. So continuous spinal catheters are they're very, very dangerous. Okay? What happens is they thought initially that the catheters were the issue because they thought it was from the propylene, the plastic that it was made from. It has nothing to do with the plastic. It has to do with the local anesthetic that you're injecting. The local anesthetic you're injecting is lidocaine, usually. And lidocaine is in 5% solution. In the 1970s to the 1990s, we saw no lidocaine toxicity at all. It was not until the 1990s, mid-1990s, that all of a sudden local anesthetic, which is lidocaine, became toxic magically. For 20 years, it was used almost extensively as a primary local anesthetic for spinals, and all of a sudden it became neurotoxic. The reason it did was because they changed the techniques. One is they used continuous spinal catheters, and the other thing they changed was they went from Quincke needles to Sprots and Whitakers, which are pencil point needles, which have an orifice that is at 90-degree bend and in the end of the needle. Instead, the Quincke has got a straight slanted cut, and when you inject that local anesthetic through that, it spreads like wildfire. Okay, I need to get a picture of this one day, but you take a 1 liter bottle of saline, then you put in a syringe methylene blue, and inject it through a Quincke. When you inject it into that bottle turns blue immediately. It's almost instantaneous. If you use a Whitaker needle, when you inject it, it depends on which way you point the needle. If you point the needle upwards, okay, which means that the actual hole is pointing upwards. When you inject the local anesthetic, you can actually see the methylene blue come out as a stream. What does that mean? It means that the medication is staying in very high concentrations as you inject it. The saving point of it is as soon as it goes up, it forms like a mushroom cloud. So it's like watching an atomic bomb going off. It goes up, and then it forms a little mushroom cloud, and then it falls. And during that event, now the medication sort of diffuses out, and it doesn't cause toxicity. But you had people that didn't realize that. They were taking the needles, put them in, and they were inverted. Now the needle's pointing straight down. So what happens is when you inject the medication, now the medication stays as a single stream and drops straight into the sacral roots in very high concentrations with toxicity. And then that's what causes a single shot problem of toxicity. So it's not that lidocaine's toxic. It's toxic at high concentrations, but it's the technique that we're using it. Okay? So don't use 5% lidocaine in continuous spinal catheters. That's not a good idea because that comes out at very low velocities and because of the high resistance to the tubing. And be always aware that if you are going to use lidocaine with a Whitaker needle, make sure that the needle is pointing upwards. Make sure that the hole is pointing upwards as you inject it. That way you get a very even spread and you won't get into trouble. So the other thing that you'll see with is transient neurological symptoms is for the same thing. It's high levels getting into single individual nerves. versus ketoconus is a disaster. Okay. Single injection may be through the pencil point needles, and what some people now recommend is limiting the lidocaine to 60 milligrams total dose, which is fine. I don't totally agree with epinephrine being a problem because epinephrine still has been used for many, many years without any effect. But they're saying that it keeps the concentration of lidocaine high, which again, this is controversial. People argue it back and forth. I still use epi when I want to enhance it, but I stick to the 60 milligram rule. It works pretty well. So some people say you should never use 5% lidocaine anymore for spinals. I've used it for 20 years, never had a problem, and I'm always aware when I'm injecting a needle where I'm pointing that needle at and never had a problem. I think that's a major mechanism. That's personally what I think is going on. But I've had a major complication with ketoconus syndrome with the continuous spinal catheter. My attending that was working with me said, "Oh, this is the greatest thing. Better, it's better than epidural because you can titrate the medication," and it was not better. And after that, you can never get me to use a continuous spinal catheter anymore. Some people will actually get into a wet tap and they'll throw the catheter in and then they use it for a spinal. I won't. The needle comes out, catheter comes out, we reinsert it one level higher, we do it that way. So I'll never use it again. It's just too much. Too much. It was too painful to watch somebody be that much discomfort. And it's never worth it. One of the things that can happen is if you put a wrench in the epidural space and then you dose the medication, you may actually get a bad effect. So it may actually get into and cause transient neurological problems. But usually they're transient. The other thing that can happen is cardiovascular toxicity. That's related to potency. Peripheral effects of local anesthetics is biphasic. The lower concentrations of local anesthetics will sometimes vasoconstrict and increase the SVR when they have the epinephrine in it. The increased concentrations, on the other hand, will cause vasodilation and then possibly cause hypotension in some individuals if you give enough of it into the bloodstream. Electrophysiologically, that's where it kills most patients, is decreases automaticity. So it decreases phase 4, depolarization, and reduces the refractory period. It also prolongs the conduction time, especially with lidocaine. It increases the PR interval and the QRS complex times. You get increased doses, increase the risk of developing severe sinus bradycardia. Then you'll start getting complete AV block, and then you go into asystole. Not something you want to see. Okay? Lidocaine, you have to give very high doses to get into that range for that to happen, though. Okay? The one that's more dangerous is bupivacaine. Bupivacaine is the one that really has a very high affinity to fast sodium channels in the heart, and that's what can get you into trouble. It also will depress contractility of the myocardium, so it has a negative inotropic effect. The R isomer of bupivacaine avidly blocks the cardiac sodium channels and dissociates slowly, which means that if you do have a cardiac arrest with bupivacaine, you're going to be doing CPR for a long period of time. Major cardiovascular toxicity requires about 3 times the concentration required to produce seizures, so you're really toxic at that point. Ropivacaine is 70% less likely to cause severe cardiac arrhythmias than bupivacaine, and that's why some people advocate its use. And levobupivacaine is also very similar to that. It has a significantly decreased incidence of cardiac toxicity. The problem with ropivacaine and levobupivacaine is that it's so expensive. It's like 20 times more expensive than bupivacaine. So most hospital formularies won't let you buy it. It's just too expensive. They just tell you, be careful. In reality, that's actually a fairly good thing to do. If you're just careful, these drugs don't give you trouble. Selective cardiac toxicity of local anesthetics, the one that's the most toxic is bupivacaine, the least one is lidocaine. The cardiac toxicity associated with these drugs is severe and recalcitrant to treatment. What I've seen in the past is that you would just do CPR for 50 minutes up to an hour and a half, and the person will eventually come back. But you've got to get good CPR. So what you recommend if that happens to you is immediately put an A-line in the individual and continue doing CPR, maintaining good perfusion pressure, and just have several people doing it. You're going to crack ribs, but don't stop. And in about 45 minutes, you'll start seeing one beep in your EKG, and then you'll get 2, and you'll get 3, and then you'll come back. It's really like, God, come on, make it come faster. Now, what's really a new therapy, which is kind of cool, is called intralipid therapy. Intralipid therapy is the same thing we use for as a care of Diprivan. And when you inject intralipid therapy in the individual, it acts like a sink. It soaks up the bupivacaine. So it immediately binds all the bupivacaine that's not bound. So that helps redistribute it because it increases the exchange rate, and it pulls it out of the heart more quickly. That doesn't mean you're not going to be doing CPR for a while. So instead of being 45 minutes, it's going to be 15 minutes. But that's much better. I mean, it's pretty exhausting to do CPR for an hour and a half. So, if you have problems, airway support, remember at this point you're much higher in CNS toxicity. This person's unconscious at that point, and usually either seized, is now into a comatose state, so actually past the seizure state, and you need to ventilatory support them. Consider cardiopulmonary resuscitation with CPR and doing epinephrine to also increase your pressures. If you try to pace individual, guess what? It won't work. Okay, you've basically knocked out all the conduction fibers in the system. You may have to consider defibrillation or for fibrillation for VFib. Okay. If you're having VTAC, be very, very careful. If it's stable VTAC, just wait. If it's unstable VTAC, then you consider doing cardioversion. But you're most likely going to go into a malignant arrhythmia when you cardiovert that individual. So be very ready to be defibrillating that individual next. Treatment, get help, immediately call for lipid therapy or local anesthetic toxicity kit. Focus and attention in the airway, seizure suppression, cardiopulmonary resuscitation, and alert facility having cardiopulmonary bypass. Sometimes you'll have to go that step if you want to keep that person alive. I never thought of it that way, but that's a new recommendation. That's pretty aggressive to say the least. Most facilities don't have CPR and cardiopulmonary bypass readily available. And it's not without its risk as well, so I don't know. Administer 20% lipid emulsion, okay, which is, that's what it comes in, which is you bolus it at 1.5 milliliters per kilo over 1 minute, which is around 100 cc's. And you start a continuous infusion, which is about 0.25 milliliters per kilogram per minute, which is about 500 milliliters over 30 minutes. And then repeat boluses every 5 minutes for persistent cardiovascular collapse. And double the infusion rate, blood pressure returns but remains low. And continue infusion for a minimum of 30 minutes. And that keeps the bupivacaine soaked in the stuff. There is danger of using lipid emulsion if you can embolize lipids into the individual, but intralipid is pretty safe. So, you know, it should be okay. The local tissue toxicity can also occur for things like fluoroprocaine. 3% has been known to cause nerve damage if you put too close to nerves. And also 5% lidocaine may also cause nerve damage. So high concentrations is what kills the nerves. Remember I told you that about how it affects the sodium channels? That's what the concern is most likely. Okay? So now let's look at allergic reactions. Allergic reactions you have produced severe allergic reactions, especially are the esters. You can have hypersensitivity or anaphylactic reactions. Esters have much higher incidence of allergic reactions, and they because of the production of paraminobenzoic acid from the ester hydrolysis. The amides, on the other hand, cause allergic reaction due to preservative methylparaben, which has a structure similar to paraminobenzoic acid. So methylparaben is the one that causes the most problem. This is methylparaben. You see it looks just like PABA. The only difference is that it's got a methyl group at the end of it, CH3, added to it. That's why it's called methyl. The other thing you can see is methemoglobinemia. This is one of my favorite discussions because people don't take this seriously. They think it's like, it's the book talks about it, but it's not a big deal. Actually, it's a pretty big deal, but it affects oxygen transport. When you get methemoglobin, the methemoglobin changes and it cannot accept any more oxygen. And you get a functional desaturation that's very prominent. The person will say 86%. That's their true saturation. And you can give them all the oxygen you want and it won't make a difference. When you take their PO2 value and their blood gas is 600, and the hemoglobin's still at 86%. Okay? So you can't reverse it with oxygen therapy. The way you have to reverse it is by giving a chemical agent, which is methylene blue. Methylene blue will reverse the methemoglobinemia and get, which is kind of funny. The person's turning blue and you're giving them a blue agent, which is kind of a weird thing. Okay, so this is what methylene blue looks like. When you drop this medication, make sure you don't get it on your fingers because it's almost like a tattoo. It'll stay in your hand for about a week. So unless you like blue, that's fine. What can produce it is prilocaine. Prilocaine is the number one agent that can cause that. We don't use that much prilocaine, except prilocaine is in part like an EMLA, so that's where you could see it. If you cut, they actually had several deaths of it. Somebody actually read on the internet that EMLA was a good local anesthetic. So these two individuals were getting their hair done via laser treatment, and it was very uncomfortable. So they decided to take their legs and cover them in prilocaine. What's even more amazing is they actually studied that the absorption rate can be much faster and be more effective if you wrap it in saran wrap. So they wrapped their legs in saran wrap, and they both died. They both died of prilocaine toxicity. They got methemoglobinemia and died when they went to the hospital. They didn't know what was going on. They didn't reverse it, and the saturation was 62% or 50%, and both women expired. So all they had to do was to save them was give them methylene blue, but they didn't know what the heck had been going on. They just saw these women with saran-wrapped legs, hairy legs, and they died. So, not good. Okay. Where you also see methemoglobinemia is from benzocaine toxicity. Benzocaine toxicity comes from this thing called hurricane spray. Great agent, okay, when you put it in the back of the throat to do an awake look, but it's just to be doing 2 sprays. You go, and you're done, okay? Because the spray works great a little bit, why not just do more? So you see people go, and you see a cloud coming out of this person's mouth, and you're going like, man, I'm getting toxic off this stuff. And then the saturation, all of a sudden you're 100%, 82. You're going, what happened? Well, you made the person hemoglobinemic. Okay, benzocaine also will cause this problem. Okay, the way prilocaine causes it produces is a metabolite called otolodine, which is what binds and causes methemoglobinemia.